Hello, everyone. Welcome and thank you for coming and spending some time with the engagement staff and other practice managers. I'll just start by introducing myself. I didn't get to the last Meaningful Mingle meetings. My name's Jennifer Burnham. I'm the Primary Care Engagement Manager. And I'll start by acknowledging the traditional custodians of the land in which we meet today and pay respects to elders past, present and emerging. I'd also like to pay respects to any of our First Nations practice managers joining us today or other practice staff. Welcome and thank you for being part of the second Meaningful Mingle session. Some of you would have received the Meaningful Mingle mugs. If you haven't already, expect your practice primary care engagement officer to drop by and present that to you shortly. I'd also like to welcome our new Townsville Practice Engagement Officer, Patricia. So Patricia comes with years of experience as a practice manager, and she'll be introducing herself to you all very shortly, offering her support, and that's for the practice managers located in Townsville. We have other members of our engagement team online. So we've got Linda and Claire in Cairns, and Deb and Carly, our lead in Mackay. And also thank you to any other NQPHN teams who've joined us today. The primary care engagement team want to make sure that general practices in our region know about the transition from PIP to primary sense. So I'm going to hand you over to our primary sense project manager, Cameron. But before I do that, if you have any questions along the way, please just pop them in the chat and we'll get to them at the end of the presentation. So thank you very much. And I shall hand you over to Cam.
Thanks, Jen. Hi, everybody. Thanks for joining us today. As Jen mentioned, we're working with a whole bunch of practices, or all of you guys at the moment, to try and get everyone on board with primary sense, which is a little bit of a change. So for a long time, practices, Northern Queensland PHN has been collecting data from practices to help with our population health planning and commissioning of services, and also providing some reports back to you guys in the practice, which we're hoping you'll find useful to help you guys do quality improvement projects and operate efficiently and effectively. And for years we've been using a product called called Cat4, and a little tag along to that called Top Bar that come from a company called PIP. And we're moving over to primary sense. So that's what we wanted to do today is talk a little bit about what primary sense is and why it's different to PIP and how to use it, and what it's going to mean for you guys going forward. So what we found was that Cat4 and Top Bar are very powerful tools that can do quite a lot in your practice, but generally we found with a lot of the practices that we work with, in fact, almost across the board, was that practices weren't using it because it was too complicated and too involved, and in the case of Top Bar, it could get a little bit unreliable. So we're hoping to fix some of those problems with primary sense. It's got a lot of the same sorts of elements. So the little tagline that we always use is that it's a population health management, clinical decision support, and data extraction tool. But what does that actually mean? Essentially, Cat4 was doing the same sorts of things, but now that we've got primary sense, it's a whole lot easier to use and it integrates better into the practice. So we're hoping you guys will find it useful as well. In terms of what it is, you can think about the information coming out of primary sense as being similar to the information coming out of Cat4 for those of you who are familiar with it. But the reports that we've got here in the reports tab are sort of pre-filtered recipes in Cat4. So when you think about how long it used to take to get a report out of Cat4, you'd have to open up the program and click the collect button and come back 2 hours later and go filter, click, and here's a report, and you'd probably have to follow a recipe because it was always too complicated to figure out what was going on. And every time you came in to do it, you would have to relearn it because it was, you only did it every now and again. In Primary Sense, it's much easier. All you would have to do is click on the reports tab and double click on one of those reports, and in a couple of minutes you'll have your information. So Primary Sense continually updates itself in the background every couple of minutes, so that the data that comes out in the reports is virtually live. There are two different sorts of reports. So there's patient list reports, which are the bulk of the reports you can see on the screen there, and there are also PHN or practice reports, which are a little bit of amalgamated data about your practice, so you can see what's going on, what sort of disease mix you've got, what your age and sex breakdown is like, and all that sort of thing. And you can use that for your accreditation as well. So you've got your RACGP fifth standards accreditation measures in there, and further down there are a couple of reports about PIP QI in your practice as well. Some of the other things that that Primary Sense includes that Cat 4 and Top Bar missed out on are one of the big ticket items is a little tool called the Johns Hopkins University ACG system, which takes a look over each patient to give them a risk stratification score between 0 and 5, according to how complex their care is. So the data that we've been looking at so far about practices and the model that we've been following has been a disease-centered model. So every time we were looking at what was going on in your practice, it would always be about, tell me about my diabetes patients, tell me about my, COPD patients. But Primary Sense actually has they call it a patient-centered data model, where instead of having multiple lists with diabetes and COPD and mental health, and we have a couple of lists about complexity that just says, tell me about the complex patients and what we can help them with. So the way we figure that out is by looking across all of those lists and saying, tell me about the health of this patient, what sort of diagnoses have they got, what medications are they taking. It even goes as far as looking at things like pathology results and hospital admission rates, to say who are the people we should be paying most attention to in the practice, the category 4 and 5 patients. And it helps people in the practice, helps the practice team look after those highly complex patients and the patients who would benefit most from interventions, by popping up things like this medication alert when the doctors are prescribing medications, or the patient care prompts for the highly complex patients. So the prompts that pop up give a little bit of information for the GPs about why they popped up, and just try and involve more people in the practice in doing things in caring for the highly complex patients. Whenever I mention prompts and pop-ups to people in the practice, they always shy away a little bit because they're worried about doctors being bombarded with things that pop up on their screens, because there's a lot of things that pop up on doctor screens. Primary Sense tries to narrow it down to only those people who will really benefit most from the prompts. So the highly complex patients. What we're seeing around the country is that about 10% of consultations are having a patient care prompt, and about 0.5% are having a medication alert. They're not designed to duplicate anything that's already existing in best practice or MD. They're just the high value, they call them high value prompts and alerts to try and make sure that you guys are looking after your highly complex patients. So that's a sort of quick overview of Primary Sense, the program. It is quite a simple program, and once you've got it installed, I encourage you to have a little play around. It can be actually quite intuitive to use. But there were a few questions that you guys put to us when we asked you to register for the Meaningful Mingle, and without wanting to drone on for too long, I've tried to narrow down a few of those questions into a couple that I can talk about, and we'll take a few questions at the end if people are interested to hear more. So one of the first ones I'll get onto, there were a few questions about why Primary Sense, what was different between Primary Sense and some of the other programs going on. particularly things like Cat4, which you're already using, and Cubico was another program that comes up quite frequently. So broadly speaking, Cat4 and TopBar are a similar sort of program to Primary Sense in that there's an element that lives on the server in the practice alongside your clinical database, and that does the data processing, so the de-identifying of your data and sending it off to a central server. And then there's a desktop app which you guys can use in the practice to investigate the data. So for Cat4, you could log into Cat4 and get all sorts of reports, and there was TopBar that helped you do bits and pieces. Primary Sense has a desktop app which lives on each computer that you want to have access to it, which provides those reports and prompts and alerts. But I'm sure you probably noticed that Primary Sense is not quite as flexible in how you can interrogate the data that comes out. But again, if you think about those reports as pre-filtered cat recipes, all you have to do is click, and out comes a report, and you can then play around with how they come out in Excel spreadsheets or use the alerts and prompts. The big difference in Primary Sense is the addition of the ACG tool, that risk stratification tool, which you can think of as kind of like putting a set of blinkers on to focus your attention. So the data that comes out in the reports and the care prompts and medication alerts is really has got that efficiency and effectiveness mantra in mind. So the reports that come out of Primary Sense include lots of elements of opportunistic care by highlighting who has upcoming appointments, for example, and that's a similar product to how people are using Cubico. So Cubico gives lists of reports of who's eligible for a GP management plan, for example. But in Primary Sense, it includes a lot more clinical detail about why the patients are due for care plans, and look, here are the people who are going to benefit most from care plans. And I think when we're talking about a cohort of patients in your practice who are high utilizers of your services, they're certainly a good group to focus on. So targeting patients like those highly complex patients removes a lot of the noise created by systems like Cubico, where Cubico is just flagging everybody who hasn't been billed a GP management plan. Hey, look, bill this person a GP management plan. So so they have similar sorts of services, but again, that the inclusion of the ACG tool and that risk stratification really narrows it down to the high value patients in the practice. So this is a report. So when we're talking about how to maximize MBS billing, for example, you could use a report like this, patients with high complexity, and this is just some dummy data that I've got out of our demo software. But patient lists like this can be used to make sure you're billing for the higher value chronic disease MBS items in your practice. So it will list who's eligible for a GP management plan, or a GP management plan review, team care arrangement, and so on. But again, because it's narrowed down to the people who are patients with high complexity, which are people with multimorbidity and polypharmacy, what we're looking at in this report are people who are probably already high users of your time and resources and are probably already being bulk billed for the majority of your services. So so they're a good group to target for those sorts of interventions. If we're already if they're already taking up a lot of your time, why aren't we making sure that we're maximizing our MBS billing, which will first of all, increase your revenue, and secondly, increase the care that's available for those patients. If we get them on a team care arrangement, and if we're maximising those 10997 practice nurse item numbers, then all of a sudden maybe we're taking some load away from a general practitioner who can see other people who are walking in through the door or waiting on a waiting list. So these reports, when they come out, won't list every single person in the practice, so they're not designed to be a patient register. that's the sort of thing that you should be able to get out of your clinical software. It's what clinical software was made for. Primary Sense was designed to be simple and easy and not to duplicate anything that was existing in your clinical software. It's one of the ways that that it can be simple and easy to use is by keeping it simple. What will appear on this report are only the people who are eligible for those sorts of item numbers. So it again puts the blinkers on and takes away some of that noise, so you don't have to filter through lots and lots and lots of different data. What comes out in the report is all you need to focus on. While we're talking about data in these reports, you can manipulate data as it's displayed to get particular lists. So you could filter by, clicking the column heading to filter by existing appointment, so that the people who are coming in today are shown on the top line. The people who are coming in tomorrow will be just below it. You could also pop certain things in the search bar to narrow it down. For example, if you wanted a list of who is eligible just for a particular doctor, then you could filter by the GP name, or you could put the GP's name in the search field and narrow it down by who the patient's nominated GP is. Primary Sense looks at the practitioner who the patient visited the most out of the last 5 visits to determine the GP name, unless it's specifically nominated in the practice software. So there's some smarts going on behind the scenes there, so Primary Sense knows what's going on. So that's what the patient reports look like. One of the other questions that we had, which covers a bit of ground, is about data management, and data security was a key consideration when Primary Sense was developed, and it was developed by the Gold Coast PHN with a number of their GPs involved. So it was developed by GPs for GPs is the tagline. It's designed to be as useful and focused on general practices as possible. But there's also that element for the PHNs that we do collect your de-identified practice data, and we keep it in a repository that contains those de-identified data extracts. That repository is not owned by Northern Queensland PHN, so the Primary Sense database itself is owned and operated by PHNs collectively in an environment called Primary Health Insights. The Primary Sense database practices the practice data extracts are held in the Primary Sense database, which is where the Johns Hopkins University ACG tool runs its eye over all of that data and sends information back to you, and periodically, every few days, Northern Queensland PHN take an extract of our practice data, which is where we keep aside information about the health of our region, and use it to create things like our health needs assessment, so that we can understand the health status of our population and the services being provided in the region, and direct our attention appropriately. When we're talking about that raw data, it can only be accessed by a couple of people in Northern Queensland PHN, and we undergo quite strict data governance training and work under very strict federal legislation about how that data is managed, and it's all managed according to even higher standards than what's mandated by the Australian government. And in terms of how that data then gets used, is occasionally aggregated data sets are used in conjunction with other organisations like our hospital and health services, again to coordinate the delivery of health services, and then creating the data dashboards that we provide back to you guys, so that you can see what's going on in your practice and at a higher level. The data that's collected through Primary Sense is never released for any purposes that could potentially identify individual practices or people or general practitioners. When data is released for those sorts of things, it's always aggregated data, there's a lot of information in the data sharing agreement that outlines, specifically what is collected and what uses are permissible for us to use that data for. There is provision that people can apply for access to use that data for research purposes, but that's not an avenue that Northern Queensland PHN are following at the moment. But rest assured that when that does happen, the provisions in that data sharing agreement outline that that we have to make sure that everybody is aware of what that data will be used for and has the chance to opt out of that as well. So when it comes to secondary use of data, it's very tightly locked down in terms of how it can be accessed. One of the other questions that we had was about data management and particularly patient consent. So nothing should be changing in your practice in terms of patient consent. You should already be offering your patients the ability to opt out of sending data to the PHN. And in primary sense, that's managed through the patients tab. You can if you have a patient who has removed consent, then the primary place that should be recorded is in PracSoft or best practice or in their patient record, which will stop any data extraction tool from extracting data. In primary sense, that goes one step further by allowing patients to be opted into being in primary sense, which then has the benefit of the Johns Hopkins ACG complexity score and inclusion in the prompts and alerts. But to exclude them from sending data from the PHN, you would have to come into this screen and click on that data for planning section to turn off sending data to the PHN. We have some resources that we can send to practices to put up in the waiting room for those practices who are interested, to let them know that your practice is signed in to primary sense. But when it comes to managing opt-in or opt-out, then that's something that you will have to monitor in your practice and make sure you're looking after your patient consent well. One of the other questions we had was how do I get primary sense in my practice? And the application is quite simple. So there is a little bit of a time element for us. So our licensing with NCS will be finishing on the 30th of June, but it takes a few weeks for us to get practices on board. So to make sure that there's no impact to your PIP payments, make sure you get in touch with us as soon as possible. That little QR code that's on the screen now will take you to the EOI form for practices to fill in if you haven't filled one in already. If you have, then keep an eye out for the data extraction and software licensing agreement to come. And the next step after that, is to get a signature on that to sign people up, and we'll be talking to IT providers to install it for you. Generally, we've spoken to quite a few IT providers so far, and they've got the installation process nailed down pretty tight. They've been really good. So that's a little primary sense in a nutshell. I think I got through that quicker than I was expecting to. Have we got any practices who are currently using primary sense? What are people's current thoughts? I know we've got a few people online who have already been using it. Anybody?
We've also got a couple of questions in the chat, Cameron.
Great. I haven't
and I might
spotted them
jump
yet.
in as well, because we've also got Patricia online who was using it very recently in her role as a practice manager.
Okay, so I was impressed with it because I'm not really smart with data. I'm the first to admit it. And I found trying to work out the recipes really hard previously. So primary sense, it's just there. So particularly if you're like me and a data challenge, you'll find this one so much easier to use.
Thanks,
Thanks,
Patricia.
Great. Thanks, Trish.
I'm just having a read of some of those questions now. The data for GPMPs and TCAs is only pulled from your own practice data, I'm afraid. That's quite a common question. I know when Primary Sense was being developed a few years ago, an integration with Proda was investigated, and I think it was found then to be prohibitive. It's certainly not off the table, and I believe Cubico have managed to do it, and I'm interested to see how. So it's certainly something we can investigate down the track, but at the moment it's only telling you what's going on in your own system. And the reason the Johns Hopkins University tool was used was, I believe, that the CSIRO model was not quite ready at the time that Primary Sense was being developed. There were concerns that the CSIRO model was not as well developed as the ACG tool, which has been around. It's been used in the United States and the UK for over 30 years. And it's got a lot more data behind it. I think it was decided to use ACG because it was slightly more robust at the time. And for Andergrove, I'm sorry, it's not available for Genie or Apple computers yet. But rest assured, for you guys, you're going to be able to continue with the PenCS products, and they'll continue working for you beyond 30th of June, but I'll be in touch to talk about what that's going to look like more shortly.
A couple more in there have popped in there now, Cam.
Yep, I'm just having a look at that one, Anna. Data, if data is sent to Johns Hopkins, the data is sent to the Johns Hopkins ACG tool. But they don't keep a repository of that data, so it's only sent to that tool so that it can analyze it and give people complexity scores and hospitalization risk. So the Johns Hopkins tool don't keep a repository of the data. Or the only repository of the data is in the Primary Sense tool. Make sense to everybody?
Cameron, just on that one from Tina about that she has the Primary Sense installed but doesn't have any idea on how to use it. Do you have some advice for her around that?
Tina, have you found it on a computer? Has it been installed only on one computer, or is it all through the practice? And have you got the icon on the desktop? Is it running? Does it start up when you open the computer? So in that case, if you've got the icon on the desktop, I'd recommend just opening it up and running your few reports and seeing what they look like. It's as simple as clicking on the little app icon and clicking on the reports. I could probably actually bring it up on my own computer if you like and show you how it looks, if you bear with me. I'll share my screen. So on my computer, it just looks like that, a little tile that sits on the side, and you can click it and drag it around to wherever you, pardon me, wherever you want to see it. So once you've found it, you click on it to open up the menus, click on the reports button, and run yourself a report. And this is using demo data. Oops, that came up on my other screen. And that's what the report looks like when you open it up. So in your practices, it will probably take slightly longer than that to open because you've got more data in your systems than I have. But open it up and have a play around. Certainly in the reports area, you can't break anything. I reckon just spend a little bit of time and open up every single report and have a little read through. There's a lot more information in the reports as well, so you can have a little look at, say, what are the patients that are in this report. You can have a little read about what the ACG complexity levels are and you know what it means to be a band 4 or 5. Jump in and have a play.
I don't
might
think
check in.
Tina has access to those reports. Maybe we'll get Cameron to touch base with you after this session, Tina, so we can troubleshoot what's going on there. Just a few more questions have popped into the chat, Cam. Are there any concerns with speed for processing the data as more practices adopt primary sense and more data is sent to the ACG model?
Certainly from the ACG model, there are no concerns about how many patients we can put through the ACG model. I think there are more people at a particular hospital in the United States that's running through ACG than there are ever intended to be running through the ACG tool that we're using in Australia. So ACG is quite robust in that sense. It's got plenty of power behind it. There are some concerns about how primary sense was originally developed on the Gold Coast, which I suspect might be where that question is coming from. That when it was developed, it has grown to include more practices than it was originally developed for, and there have been quite a few changes in the background to make sure it can handle the increase in processing required for that. There are more changes in the pipeline that will make sure that it will be able to handle the amount of practices that come on board. So it's certainly a consideration, but it's not one that I'm particularly concerned about, because there is quite a lot of activity in the pipeline to make sure it will be robust and available and perform admirably. The provision of reports in primary sense can sometimes take a little while if you've got quite a large database. You know, if you find it takes a little while to load a report, you know, that might be because you've got quite a large database, but certainly it should be faster and easier to use for all practices than the PenCS tools.
Sorry, Cam, I just see
you know,
Janine's dropped a resource there in the chat for practices to have a look at.
Yeah. So there are really good resources online. So there's that one that Janine's put in. The videos that are available online for how to use it are quite comprehensive, and there are a few other resources that people like the Gold Coast PHN have put together as well, with some more specific topics that we can circulate when we send out our information. In terms of PIP QI, because primary sense is continuously updating itself in the background, your data is always updated. It's not like PenCS where we get once a month we get a data download from your practice. It just happens continuously in the background. In terms of PIP QI submission, I will double check with Bianca. I think we actually already send out a notification when we submit your PIP QI data, which happens quarterly, and that process won't change.
And post this meeting, I might just add that we'll send all the links to the resources and videos for anyone that hasn't received those yet, and along with a recording of this if you wanted to share it amongst your teams. Any other questions?
I'm looking forward to getting everyone on board.
So if you haven't sent in your registration form, yeah, just get in touch with the PHN and we'll send that link out to you and get someone to contact you around getting primary sense installed.
Great. Is everyone excited? good news. Is anyone using it already? Has anyone tried it? And
Another question.
Who was that practice manager? I haven't got a name, I'm afraid, but certainly in terms of PIP submission, the data in Primary Sense is continuously up to date. So it's not like PenCS where we did a data extraction once a month. Primary Sense just keeps itself up to date all the time. So so there's no monthly data submission, but when we submit that data to the Australian Institute of Health and Welfare quarterly, I think we have a process whereby practices are notified that that their data submission was successful for that. But in terms of monthly data submission, there's no need to make sure your monthly data is submitted to us, because when Primary Sense is running, it just happens automatically. PenCat and TopBar at some point will have to be uninstalled from your system. So practices can certainly continue using PenCat and TopBar if they quite enjoy it. You know, the two systems can run side by side, but you would have to contact PenCS and pay a license fee directly to them if you want to keep running it. Once I've got a little bit more instruction from PenCS, we'll be sending out some instructions which will probably say, please uninstall PenCat and TopBar.
Cam, could you explain to those that have got Genie and unable to use Primary Sense the process that they will have to go through?
I'd love to, Deb, but I don't know what it is yet.
Okay, yeah.
So at the moment, all I know is that the practices that can't use Primary Sense will have to remain on PenCS, and at the moment I don't know exactly what that's going to look like. But we'll be talking to PenCS about that. I think in the next couple of weeks. So I should have a bit more information to be able to tell those Genie practices.
Thank you.
Oh, well, that was a little bit quicker than I thought. Thanks for questions, everybody.
Hopefully everyone will be emailing you now and asking you how to get on board.
I hope so, yeah.
There's just another question come through there.
Yeah, I've seen that. I'm trying to work out what that question is. The PenCS data submissions are currently sufficient for PIP QI, but that situation will be changing for the practices that are on board Primary Sense on the 30th of June. So by the 30th of June, we need to have practices on board.
Any more questions from anyone? Okay.
There's another question there from Andergrove, Cam.
For those who can't need to stay on
yes.
PenCS, so PenCS will be your data submission tool for PIP QI. It will either be submitting data for you, or there will be a manual process. I just don't know what that's going to look like yet.
Helena, I'll keep you up to date with that one, love.
We're going to continue running these meaningful Mingle sessions. They came about through surveying the practice managers, asking them, you know, what topics they would like to see, when they would like the sessions run, what time, so forth. So this is what we came up with. So if you We originally have decided to run them quarterly unless there is something that we think needs to be, that you would be interested in addressing it earlier. So that's why we've run this session so close to the first one. If you have any topics that you feel that you would like us to run a session on and you'd like to come together with the other practice managers to discuss something, then please let us know. You can do that by contacting the team. You can put in a request through our practice managers updates that we put out monthly. So keep an eye out for them. And if you're not subscribed to them, I think it's a really good idea for you to do that. We try and keep them short, sharp, concise information just for practice managers. So it's not something that you have to scroll through loads of information to, find something that's relevant to you. So we try and make it as relevant as we can to practice managers without having too much information in there. We have links to more information on stuff, so we don't have big, long paragraphs of topics. So, yeah, if you're not subscribed to that, please get yourself onto there. Is there any more questions?
I've just noticed that a couple of people have been asking for that poster. So I'll make sure that poster is available. We'll probably print out a few. It'll be A3 size, and we'll get the PCE team to your PCE rep to deliver them.
Excellent. Thank you, everyone. Thank you for your time today, Cameron, as well.
Thanks, everyone. Yeah, shoot through any questions. I'm here to help if you need me. But yeah, I'd love to get you all on board.
Yeah. So if you've had any questions that you wanted to ask today and been a bit shy to put them on the chat or don't want to come forward and ask, please just contact us, and we'd love to speak to you. And thank you very much for joining us. See you at the next one.